Hi, everybody. Thanks for joining in. So, very honored and thank you so much, Tanvi, for joining us. We have Dr. Tanvi Sood with us. She's a medical oncologist at Paras Hospital in Gurugram. She completed MD as the gold medalist at Bareilly, SRship at Safdarjung, DNB Medical Oncology in Manipal Hospitals. She's also certified by MRCP in Medical Oncology and the European Society of Medical Oncology. She's a recipient of many prestigious awards, national awards and international awards. It's such a pleasure to have you with us, Tanvi. So she'll be uh, throwing a little light on precision oncology and help us understand precision oncology a little better, because nowadays everybody is going towards precision oncology. And the first question many of our patients in our practice also ask how they can apply and when is the right time to use precision oncology. So to just start off the talk, so what exactly is precision oncology? It's the science of using each patient's individual genetics, the genes that are mutated that are causing the cancer to grow, to create a treatment protocol that is just for them based on those genetic mutations without causing too much trouble or side effects to them. So when do we usually use precision oncology? What is the goal of using this? The basic goal is to be able to give the right cancer treatment to the right patient at the right dose and at the right time. I hope I covered that good enough, Tanvi. So I wanted to ask you, how is it done? Like, what does it include? What exactly does precision oncology include?
Right. Thank you, first of all, Dr. Karan, for having me on this discussion. And definitely, it's a very happening topic. So, you've given a great introduction to it already. Precision oncology is something like a personalized medicine. We're moving more and more into personalizing treatment for each patient's cancer, because by and large, now everybody is aware each person's cancer is different. One lung cancer is not the same as the other lung cancer. So, personalized medicine or precision medicine in its essence truly means that we precisely target what really is causing cancer in the individual, right? So to begin with, of course, when we want to find out how can we implement precision oncology in our patients, the first and foremost thing that we require is a tissue sample or a blood sample. So tissue sample is definitely from the cancer tissue itself, because we are trying to analyze if there are any biomarkers that we can catch, if there are any mutations that we can catch at a molecular level with specialized tests. And these tests are very easily available now in almost all hospitals and large lab chains, and they're more and more accessible and actually becoming more and more affordable also, with Indian players coming into the scene. So these kind of tests where we are able to do specific gene testing or biomarker testing with the help of platforms like next generation sequencing tests or hotspot panels, certain biomarkers that can be tested in the blood itself with tests like RT-PCR or even FISH analysis. This may sound very complicated, but actually it's everyday jargon for an oncologist now. So it's very easy to go ahead with precision oncology in our patients, because when we analyze our patient, when we establish a diagnosis for our patient, a very important step of it is to test for these biomarkers or gene mutations using either the tissue or a blood sample.
So that's a very good point that you brought about, that initially when NGS first started, next-gen sequencing first started, it used to cost around 1.5, 2 lakhs. I remember Data Genetics used to cost, charge at least 2.5 lakhs for it. Now we have,
Correct.
different panels ranging from 15, 20,000 also, depending on the number of particular genes that we need to do. We don't always need to do all of them together. It is very precise to what the patient needs and what the doctor needs from them. So,
Absolutely.
your clinical practice, what are the ideal candidates? So, what are the different situations that you would use precision oncology?
See, precision oncology, it gives us a lot of advantage therapeutically, of course, because it gives us more and more tools apart from conventional chemotherapies or monoclonal antibodies, what we're already used to, I mean, these agents have used for decade after decades. But now, from a therapeutic standpoint, we are getting more and more armed with more tablets, more injectables that can be, targeted to the patient's mutation itself. So, therapeutic indication is foremost. The second part of it is prognostication also. Whenever we deal with cancer, the patients in our OPD first of all ask us, how bad is it? What the
Correct.
prognosis is like. And we know that, traditionally speaking, the stage of the cancer helps us a lot. But now in today's era, every stage 4 is not a death sentence. And that has only become possible because of precision oncology. So if we can get to know a cancer at its molecular level, we can also guide our patients, whether, let's say, a breast cancer patient with hormone positive, HER2 negative disease is coming to me in stage 4. The prognosis is not as bad and grim as, let's say, to a patient that is a triple negative breast cancer patient in stage 4.
Correct.
So we know that even in today's time, when we have mutations that can be detected in these kind of patients, we have more and more options. Apart from hormonal therapy, we have PIK3 inhibitors that can be given to patients that carry PIK3 mutations, and thereby delaying chemotherapy required by, more than 5 years also in so many patients. Even for HER2 positive patients, now we have n number of anti-HER2 medications available to us. So again, that's only possible because we're able to target the HER2 protein, right? So
Correct.
again, prognostication is very important, where I can tell my patient upfront, even before starting therapy, that look, if you're carrying this mutation, if there is a BRCA mutation in a breast cancer patient, I know the prognosis is not as good, not as favorable, right? So we're able to prognosticate. And the third application of precision oncology, which is still not very mainstream, but has come in the domain of, let's say, breast cancer, certain familial hereditary cancers, that is screening. So there are patients or there are individuals who are at a high risk of having or carrying these gene mutations. So BRCA mutation is something that a lot of people are familiar with, maybe because of the Angelina Jolie effect also, the news that rang around, everybody knew that she went through bilateral mastectomies. Why did that happen? Because there is this common gene mutation known as the BRCA mutation that increases a person's lifetime risk for breast cancers and ovarian cancers. So now we know that if there is a person in whose family a person is already carrying BRCA mutation, so it portends a high risk for all the first degree relatives, and we do genetic counseling and guide them that they can undergo this BRCA testing also. Or there are people in whose they have a very strong family history. Two or more people are suffering from breast cancer, ovarian cancer, or men with breast cancer, or a cluster of cancers that are closely related, like pancreas, prostate,
Yeah.
breast. It may sound bizarre to unconnected, disconnected to an everyday person, but to an oncologist, it immediately alerts, okay, I need to look for BRCA for this patient. So that
Correct.
is the preventive aspect of it, where if I can catch a person before they're even developing cancers, if I catch a BRCA mutation in such a patient, I can guide them that there are surveillance options. There are ways to catch a cancer, in a very early stage, so it's still curable, and we can do risk reduction surgeries also, like we already mentioned, bilateral mastectomies or oophorectomies, and so on and so forth. So precision oncology has really empowered us in many ways in making oncology treatment even more and more effective and leading us towards cure also in many cases.
Correct. So to take away from that, so basically precision oncology is used in three different ways. One you said is screening, that is preventive oncology. Second is, like you said, every stage 1, every stage 2 is not the same. So we are able to prognosticate, maybe even tailor the treatment a little bit to make it more intensified if needed to make sure that we get the best results. And the third part is, it is, making sure that even a cancer patient coming in stage 4, for him, it is not a death sentence. Because of precision oncology, we have come, way forward in getting so many different options for them in trying to improve their quality of life, even at that end stage.
Absolutely.
So next question, Tanvi. So if once a patient comes into your clinic and asks for precision oncology, imagine it's a stage 4 cancer. So what are the factors that you look at, whether for this patient, or, in terms of what kind of tissue that you are going to take, what kind of genetic testing that needs to be done? Like we just mentioned that there are different panels, right? So at what level would you say you want all possible, or would you tailor it to a few, depending on the stage and the type of cancer.
Right. Okay. So see, we have enough data to guide us in a certain type of organ, certain type of, let's say, solid cancer. What is the best sample to test for? Let's say, for an example, if I have a stage 4 patient that is coming to me, let's say, ovarian patient is there, ovarian cancer patient is there. So now in today's time, we know that there is something known as HRD testing, and it tests for
Mhm.
all the BRCA and BRCA related cancer causing mutations that can be done in that same panel only. So this
Oh,
testing can be done on the tissue, and even when lung cancer patients come to us, we prefer that the initial NGS panel or the hotspot panel to look for those particular mutations that should be done on the tissue itself. Now, that being said, many times in our patients, we are faced with the challenge where the tissue is either not accessible or not available, right?
correct.
Or the patient is not willing for a biopsy. Let's say there is a patient that is already a known case and relapses later on, and now I need to do these molecular tests, but I don't have a tissue available to me. So now we do have something known as a liquid biopsy as well, and liquid NGS can be done on the blood sample itself. So we know that there are circulating tumor cells even in the blood, and we're able to sequence these mutations even on the blood sample. So, as a preference, definitely, I would say for most cancer-related mutations, we prefer tissue. But if there is something like a hereditary syndrome, like we spoke about BRCA1 and 2, that can be
Correct.
easily done. So, germline tests are always done on the blood sample. Anything that is hereditary, those are preferred to be done on a blood sample, and
Right.
anything that is cancer-related, that can be done on the tissue itself for the somatic mutations.
Okay. So in terms of cancer, when you sometimes, like you said, don't get the tissue and you go ahead with liquid biopsy, what is the sensitivity and the specificity of liquid biopsy? Will you get equal results when you compare it to a tissue biopsy? Obviously, you would prefer tissue, but up to what extent can you still follow a liquid biopsy?
So, now with the latest advances, actually, it's highly concordant. So, the platforms that we are using these days, liquid and tissue biopsies, they are almost equal, if not
Mhm.
lesser, right?
Oh,
So, we can actually depend on liquid biopsies, and it simplifies our problem a lot in the cases where the tissue is not available.
okay. So now that we already covered the benefits of precision oncology. So just for everybody to understand, let's divide it in terms of examples. So in preventive oncology, which are all the types of patients that you would recommend that they get a BRCA mutation done, whether it is a patient or anybody in their family as well.
Yeah. All right. So, like I already touched upon it lightly, these are high risk individuals. So, who are high risk individuals? A is, of course, if I know that in this family there is already a person that is suffering from breast cancer or ovarian cancer and is known to carry that mutation, right? Whether it is BRCA1 or 2 or ATM, check, PAL-B2, there are so many mutations that could be possible
Right.
that are high susceptibility genes for causing breast cancers. So most commonly BRCA, that's why we take that example. So one is, of course, if a family member is suffering from it, and then we counsel the sister, first degree relatives. So
Correct.
whether it is the siblings or the children or the parents. So counseling is always done for these individuals that they can go through the same genetic test. So the test is first always done in the index patient, the person who is diagnosed with cancer. And then
Mhm.
the family members can be counseled for it. The second factor is that if there are individuals in a family, if there are two or more relatives, but at a young age they are developing breast cancer, less than 50 years or so. So this also gives us a high index of suspicion that maybe there is something hereditary running in the family. And there are often times, just to give an example, when ladies come to our clinic, we always ask them for, the family history. Uh, if they tell us that my maternal aunt had it, my mother also had it. Our maternal aunt's daughter also had it. So, we know that there is some clustering in the family happening. And if it's especially happening at an age younger than 50 years of age, then again, we can guide our patients to go for a genetic testing like the BRCA test, right? And again, of course, if there are, male breast cancer history. So male breast cancers, 99% mostly they're caused by the BRCA2 gene itself. So again, that's giving us a high level of suspicion that this individual could have a high risk of carrying this mutation. And of course, anybody who has had a history of breast masses more than two primaries at a time, two or more than two primaries at a time, or someone who had a history of ovarian cancers, these patients should definitely get tested for BRCA mutation.
Any other hereditary cancer that you would suggest genetic testing for in the family?
So these days, even for colorectal cancers, all our patients, especially who come for stage 4, we get them tested for MMR. And MMR, it helps us in diagnosing a syndrome called Lynch syndrome. And these are the kind of patients in which there can be clustering of various cancers, most commonly colorectal. They can have endometrial cancers, cervical cancers, GI-related cancers, anything related to the gastrointestinal tract, right? So gallbladder cancers and so on and so forth. Although the most common are colorectal and endometrial.
Yeah, Tanvi. So the next question, apart from breast cancer, can you think of any other examples for hereditary cancer where you would suggest the family to get genetic testing done?
Yes, absolutely. So even in our colorectal cancers, we are doing a testing called as a MMR test or a MSI test. So this is done in it's done in all stage 4 cancer patients. And this test is also again done on the tissue itself. So this helps us in catching a cluster of patients that could be suffering from something called as a Lynch syndrome, especially when these patients they have a very significant family history of 2 or 3 members suffering from various cancers like cancer of the colon, cancer of the uterus, cancer of the rectum, gallbladder, hepatobiliary cancers, pancreatic cancers. So, these are the cancers in which it comes to our mind that maybe they are connected. And although it's very rare, but now as a standard, all patients of stage 4 colorectal should be tested for MMR. And if we're able to catch these patients and MMR is positive, so one is obviously diagnostic. We're able to help our patients and, guide them for further screening in other individuals. And if there is a person who has not already developed cancer, we can guide them with screening, help them with early colonoscopies, early transvaginal sonographies. We can guide them how to catch these various cancers early. And if someone has already developed cancer in this kind of a patient, so MMR also acts as a great biomarker for immunotherapy. So these are the patients that respond very well to immunotherapy in their cancer treatment. So there was recently a lot of rush about it in the media. Also, I'm sure you also read it where they were talking about a group of 12 patients completely cured of rectal cancer of the stage 4, right? So dostarlimab was used especially in MMR deficient patients, and that is nothing but immunotherapy showing its magic in MMR deficient patients, which
Oh,
again act as a great precision oncology example.
great. So moving on from preventive oncology, we'll move on to your clinical indications. So could you, tell us of one good example that precision oncology was very, very helpful in tailoring the treatment for a patient?
Oh gosh, so it has completely revolutionized the treatment of lung cancer, lung cancer patients, especially stage 4 patients, and now even for earlier stage cancer patients. So what has really changed in the space of lung cancer is earlier a stage 4 cancer hardly had any survival, 5% by the end of 1 year. And it was very abysmal actually. Only agent available to us was chemotherapy. And even amongst chemotherapy, hardly survival of on a, just a median of 1 year or so. But with the advent of precision oncology and molecular testing, what we've been able to understand is that cancer is not always caused by smoking. So
Yes.
we wonder that, there are patients who don't have a history of smoking. Why did they still develop lung cancer? There are so many people who ask us, Doctor, I do yoga, I have a good healthy lifestyle. Why did I still get cancer? So there lies the answer. For lung cancer, we're able to do molecular testing on the tissue again, and we're able to detect mutations, common mutations, especially in the non-small cell kind of lung cancer. And amongst that also, there are two histologies, adenocarcinomas and squamous. So in the adenocarcinoma subset, which is the most common subset of lung cancer actually, we've discovered that up to 60% patients are carrying one mutation or the another. So that is
Yeah.
a huge number that was being missed earlier. And these mutations are now targetable. They are called driver mutations. By driver mutation, we simply mean that it's because of this mutation that the cancer growth is happening and it is out of control. If you're somehow able to target that mutation, we will switch off the cancer formation altogether. So there are common mutations like EGFR mutations, like ALK mutation, ROS mutation, HER2, BRAF, RET, MET. I mean, I can go on naming these mutations. Why? Because in today's time, we have medicines for each and every one of these mutations. So
Yeah.
it's truly remarkable. We are able to treat our patients of even stage 4, even the patients who come with brain metastasis with simple tablets every single day. And we can delay the usage of chemotherapy more and more later. To add to this, I would like to say patients who have these mutations, like I answered earlier, also prognostication point of view. So we've
Correct.
seen that patients who have these mutations, let's say EGFR or ALK, and if they're able to get treatment with ALK inhibitors or EGFR inhibitors, they actually have a much longer survival as compared to those who don't carry a mutation. So when we see
Correct.
a mutation, we are actually pleased because we know that we can offer a very good treatment modality to our patients and to the tune of even 5 years and even 6 years for even stage 4 lung cancer. So going from hardly 6 months, one year, and then going on for 5, 6 years and beyond, it's a
Yeah.
remarkable change in itself. So lung cancer is, I think, a one shining example for precision oncology.
Okay. Great. So when we talk about precision oncology, when we say precision oncology, what are all the treatments that are available? What is that you generally use in your practice regular?
Right. So, just to simplify it, like I already mentioned, there are oral medications and then there are injectables also. When we
Correct.
talk about oral medications, there's something known as TKIs, tyrosine kinase inhibitors, and these are I'm just talking about the type of medication. So they
Correct.
can be targeted at different mutations. Like I already
Correct.
mentioned, EGFR mutations are there. So
Yeah.
there are different first, second generation, third generation TKIs that can be
Correct.
targeted for EGFR itself. Similarly, for ALK inhibitors, also we have so many types of ALK inhibitors, and now the latest ones like lorlatinib, and so they're able to portend an excellent survival benefit for our patients. And these patients are cancer free for even 3 and 4 years and beyond. So,
Correct.
other than that, when I talk about injectables, so when I mentioned earlier, HER2 is there.
Yeah.
So
Correct.
HER2 protein is present in breast cancers, and whenever we detect a breast cancer in any person, we always do an IHC test, which guides us whether the patient's cancer is driven by hormone receptors or is it by overamplification of this HER2 protein, and or whether it is a triple negative kind of a cancer, right? So HER2 protein itself acts as a great target where we are able to give injectables like anti-HER2 medications. There is trastuzumab that has always been around. There are new medications like pertuzumab, now TDM1, and Enhertu that's coming up, which is the latest one. These drugs have completely changed the survival outcomes for such breast cancer patients, where we are seeing that even with stage 4, the patients are alive beyond 5 to 6 years.
Yeah. Yeah.
So these are the injectable formulations. Then again, there are other tablets that can be targeted towards unique mutations like BRCA. So there's something known as PARP inhibitors, which is also
Correct.
very easily available now, available in India. We're able to give benefit of BRCA mutation medications for patients in breast cancer, both in stage 4 as well as in curative setting also. So for
Yeah.
patients who have BRCA mutation and they have been given a curative surgery, chemotherapy, after that, we can follow it up with 1 year of olaparib. There is very good data with PARP inhibitors now where we are seeing that these patients are living longer with the benefit of such tablets. Then I had mentioned about PIK3 mutations in stage 4 cancers for hormone positive breast cancer. So, patients who were progressing on hormonal therapy, after that, the outcomes were not very great in such patients. But
Yeah.
now we know that almost 50% of them could be carrying a mutation known as a PIK3 mutation. So we
Yeah.
have tablets like alpelisib, PIK3 inhibitors that are targeted against these kind of mutations.
Yeah.
Even for prostate cancers, Even for pancreatic cancers, BRCA mutation is now a must mandatory testing because we are able to give them benefit of PARP inhibitors. So I think the list can go on and on
Right,
and on.
right.
There are so many rare mutations also for which we
So
have, drugs
yeah, so
available. I
so
recently started a patient on RET inhibitor, which is not even available in India. So it's a very exciting space, that
I
we are
know.
living in right now.
So the follow-up question to that. So what I wanted to ask you is immunotherapy considered as precision oncology? Because what you're talking about is targeted therapy. It's very direct to say that that targeting these genes, so it is targeted therapy using precision oncology, right? So when you say immunotherapy, that does that also come under precision oncology?
See, so immunotherapy, I would say again, is a generic form of treatment, like how chemotherapy conventionally it's a cytotoxic medicine and it blindly acts against all cancer cells, right?
Yeah, yeah,
Similarly, immunotherapy also, it will act against all cancer cells. What it is essentially doing is it is upregulating our own immunity. It's
right,
teaching our immune cells how to again see these cancer cells, unmask them, and then go and attack them. So there is
right,
something known as checkpoint inhibitors. Now that being said, where precision oncology comes in the space of immunotherapy is like I mentioned the biomarkers like MMR testing. So
yeah,
MMR deficient patients, that is a good way of assessing where immunotherapy will work. So this is known as a predictive biomarker, right?
oh,
And
oh,
another one, a very good dynamic biomarker is PDL1. So we know
hmm,
that PDL1 positivity, wherever PDL1 is high in our patients, especially in lung cancers, it has been seen that these are the patients that give a very good response to immunotherapy. So I wouldn't say immunotherapy is precision oncology, but immunotherapy can definitely be used precisely in patients where we know that yes, this patient will do better on immunotherapy as compared to another patient where maybe PDL1 is zero. And because these are very expensive medications also, so these kind of biomarkers guide us where truly the immunotherapy is going to be helpful and where not at all. We can help our
got it.
patients with that kind of counseling.
Correct. So precision oncology is basically guiding immunotherapy, but in the true sense, you wouldn't say that immunotherapy is actually precision oncology. Correct. So anything else that you would like to add, Tanvi? So I wanted to ask you to kind of summarize, generalize, and say what is the present status, and what would where do you look the future going in precision oncology? See, because a lot of our patients ask me when I keep telling them that you get this gene testing done, you have these tablets that can target these genes, you can get the treatment done with lesser side effects. Same thing with immunotherapy. You keep telling them that side effects are comparatively lesser when you compare it to chemotherapy. So, what do you say about this? Because immunotherapy, targeted therapy, has not come essentially in first line yet. Still, chemotherapy is considered to be the most effective form of treatment, in a curative state. So, what would you tell these patients? Why not in the first line, and in the future, would you see immunotherapy being the first line of treatment?
Right. So, I would want to answer this very holistically. When we talk about these new agents, it's not always that it has to necessarily replace that what's already going on.
Hmm.
There are enough trials that guide us that in which setting immunotherapy may be better than chemotherapy. Like I mentioned about MMR deficient colorectal cancers. So in stage 4 cancers, we have data where these patients may do better on immunotherapy upfront. But to talk about these tools, it's always better to imagine them working together. This is actually an adjunctive therapy. So even
Hmm.
when we speak about lung cancers or head and neck cancers, now cervical cancers, endometrial cancers, the first line data is actually emerging for combination of chemotherapy and immunotherapy. So even when we talk about talk to our patients in the OPD, they come with the notion that immunotherapy is better than chemo.
Yeah,
So it's
yeah,
actually totally dependent on the situation and the type of cancer. Like we talk about kidney cancers or melanomas. These are immunogenic cancers where chemotherapy has never shown any kind of benefit. These are the cancers which have shown remarkable success with immunotherapy. And we
hmm,
are offering first line immunotherapy in combination with TKIs for such patients also. And when I
understood.
talk about head and neck cancers or lung cancers, if there is no driver mutation in my patient, if I can't give them targeted therapy directed to a mutation, then I'm able to offer them a combination of chemotherapy and immunotherapy, which has been shown to be much, much better as compared to chemo alone. Now, to answer your question, where can it be a first line preference? We
Yeah.
spoke about PDL1, right? So we know
Yeah.
wherever PDL1 is more strong, more than 50%, where the patient is rather stable, we know that we can do away with chemotherapy in such patients, because why face those side effects if we don't really require them, right? So these are the patients where immunotherapy alone is also known to be very, very effective. So again, precision oncology essentially by the word means where we can precisely choose for each patient according to their individual tumor what is the correct need for them. And targeted therapies, immunotherapies, they are coming more and more in first line. In fact, we are starting to use them in neoadjuvant setting also, even in curative setting. Where let's say triple negative breast cancer patients are now being offered chemotherapy plus immunotherapy to downsize their tumors before we offer them surgery. And this can be followed by a PARP inhibitor for a year if a patient is carrying a BRCA mutation. So that is the wonder of immunotherapy and targeted therapy, where it is coming in helping the existing chemotherapy. So I think all these tools are heroes and they have their own importance when it comes to cancer treatment. And in today's time, definitely I would say that the area of precision oncology is brimming with a lot of research. And the best part is that in India, we have access to almost all medications, even the medications that are available outside, not in markets yet over here right now. They can be procured on compassionate basis. So there are many ways to make these medicines available to our patients in today's time. And almost every oncologist working in a proper cancer center, that to my mind, I feel that everybody is practicing precision oncology like it rightly should be.
That's true. So, getting these panels done, especially for cancers like lung cancer, breast cancer, it has become a standard of care, right? So, every patient, no matter what stage it is, we have to get these panels done.
Absolutely.
So,
Yes.
any last message, Tanvi, for everybody watching?
So last message in this, today's talks context would be that I would want to again make patients aware and people aware in general that each cancer is different. And many times we see people who are disheartened even by the news of it, obviously, and they lose all hope and they think that I had a relative or I knew of somebody who had the same cancer and they didn't survive much. Things have really changed a lot, and maybe that person's cancer was entirely different from what this person, any of your family member or a new patient who's been diagnosed. It could be a completely different cancer altogether. So
Yeah.
proper diagnosis, timely diagnosis, and then proper investigations. Before that, we should not jump the gun. There is a lot of hope in this space, and the more we are identifying these mutations, we are getting closer and closer to the word cure in cancer, which was unheard of, even 5 years back. So
Right.
that's the message I would like to leave everybody with. That is the power of precision oncology.
Thank you so much. That was a wonderful message, Tanvi. So, just to summarize, what I would like to tell everybody is, like we discussed in this talk, precision oncology can be used in different ways, whether it is for preventive oncology or whether to prognosticate your tumor and cancer or to prolong your life even in stage 4 cancer. Whatever it is an added weapon that we have apart from the existing weapons to treat cancer, to cure cancer. Do not get overwhelmed by the fact that you keep hearing and seeing online everywhere about immunotherapy or precision oncology. Like Dr. Tanvi has very clearly told us that we need all of them together in combination. So the best thing for you to do is go visit your oncologist, no matter what doubt you have, what state you are, whether it is for prevention or for cure. Do go visit your oncologist and sit with them and make sure that you get a lot of clarity in this and do not listen to hearsay and what you read in the newspaper and Google articles. So thank you so much, Tanvi. It was a pleasure having you. I hope we covered this topic comprehensively enough for everybody to understand. And if not, if you guys have any more questions, you can reach out to either of us. Thanks, Tanvi.
Thanks a lot. Thanks again for the great discussion.